Hi, everyone. We're going to get started in 15 minutes. Dr. Winter will be here. So if y'all just want to hang tight, she'll be here in 15 minutes.
shortly. Just for everyone who I have not met personally before, my name is Ashley Winter, and I am a board-certified urologist, and I am the Chief Medical Officer at Odela Health. And I am so excited that we're making time for education during lunch, and yeah, and I hope to do many more of these. And I want this to be informal. So if you have questions, would love to answer them. I do have some questions that I've put into the presentation at the end that I'll definitely address as well. Maybe Stacy, if you see like a question come up in the chat, let me know and I can
Will do.
jump to it. Yeah, so I think that's it. We'll jump in. Let me share my screen. Okay, for some reason it says that I can't share my screen.
Try now.
Okay. Aha. Yes. 1 second. Okay. And then I will put this in slideshow mode. Okay. So everyone, the topic today is just a brief overview of some aspects of hormones, specifically as they relate to female pelvic health. The title here, which was Hormone Facts to Explode Your Brain, is somewhat sensational, but I like getting people jazzed up over these topics because they're awesome. So we'll dive in. And again, with a bunch of these things, I could probably give a 2-hour-long talk on any of them, but we can always go back to them in the future. So overview, and I know also so many of you are super educated and advanced on the topics of hormones and pelvic health. So certainly I apologize if I'm telling you something you already know, but I personally always love a refresher, and I like given our shared mission, of advancing women's pelvic health and of course pelvic health in general, I thought it was important to just highlight some of the really core learnings that I personally love to repeat again and again and again and again, because they're so basic and so important, and a lot of our patients are just not educated on these things, unfortunately. All right, so GSM, genitourinary syndrome of menopause, is going to be the first thing I mention, because that is kind of the one of the core topics that comes up. Androgens and female sexuality is another one, and then we'll do some questions that I've received in the past. Okay, so here, this is one of the core things that we treat, both as pelvic health professionals and also specifically at Odela. So genitourinary syndrome of menopause, it's basically how low hormones, specifically low estrogens, affect the genitourinary structures, right? So as you go through menopause, and then after menopause, you have lower levels of estrogens and androgens because of reduced production by the ovaries. This can happen of course, from natural menopause or from a surgical menopause if your ovaries are removed. And there's a whole lot of changes associated with this. And it's so important to discuss because, in popular, in kind of the mainstream media and popular discourses around menopause, there's discussions of hot flashes and fatigue and emotions. But very rarely, if you're watching a media portrayal of menopause, is there, the actress sitting around being like, my vagina feels dry, or I'm peeing frequently, right? But these are huge aspects of the effect of menopause and perimenopause on quality of life, and they're important. So, just as a reminder here, in this slide, you can see on one half, the one I'm highlighting here with my cursor, you have a well estrogenized vagina, and then on this side, you have a less estrogenized vagina, right? So you see some of the differences, right? Your symptoms are going to be genital dryness, reduced lubrication in response to sexual stimulation. And I think that's so important, also to hone in on this reduced lubrication, because we oftentimes have patients come in and, not only are they feeling this baseline dryness, but they're saying, oh, my partner used to stimulate me and I would get aroused, right, and wet, and now I'm not doing that anymore. And sometimes they're thinking it's a problem with them, it's a problem with the relationship, and certainly there can be problems with relationships and sexual interest, but oftentimes there is a very real physical component of this that can be addressed, and specifically addressed with really simple, safe treatments. Okay, so other symptoms: pain or discomfort with sexual activity, bleeding after sex because you're having tearing of tissues, decreased arousal, as I mentioned before, and orgasm. Super important also to hone in on the bladder symptoms, and I'll discuss this later, but pain with urination, urgency, frequency, susceptibility to urinary tract infections, and also feeling like you have a urinary tract infection when you don't have one. So you can have both, right? Somebody can come in because of their GSM and say, hey, I'm getting all these UTIs. Similarly, there can be somebody who comes in and says, hey, I feel like I have UTIs, but the doctor keeps sending the urine culture and I don't have a UTI, but I know I have these feelings, right? That is classic for GSM as well, right? And so again, you're seeing in this picture, loss of folds, this kind of smoothing of the lining of the vagina, loss of elasticity. You have reduced blood flow to the area. You have shortening of the vaginal length and narrowing of the opening or the introitus, right? So you may also have a patient who maybe you're examining them or trying to do internal work on them, and it's the opening to their vagina is a finger can't even go in, right? And of course, that person is not going to be able to have penetration without discomfort. And treatments for GSM are remarkably effective in addressing those type of findings. So another aspect of the hormones, the hormone management of GSM is using vaginal estrogen, right? This is the classic treatment. It is extremely effective. I know many of you know this, but I just love to repeat it all the time. We have not seen that low doses of vaginal estrogen increase blood clots, strokes, breast cancer, uterine cancer, none of that, right? And this study is basically, they took this subset of patients in this WHI study that were only using vaginal estrogen and looked at their outcomes. And I should backtrack a little bit, right? You may have patients who have been prescribed vaginal estrogen. It comes with this black box warning saying, hey, there was this Women's Health Initiative study, WHI study done, and it showed all this bad, scary stuff from estrogen products, right? And it showed that there was increased risk of stroke, breast cancer, uterine cancer, all this bad stuff, right, using vaginal estrogen. But the important thing to know is that in that study, right, it was derived from predominantly giving patients oral systemic estrogens, right? So treatments intended to raise the blood levels of estrogens and medroxyprogesterone, which is actually a progesterone that has corticosteroid effects, and actually a lot more side effects than if you used like a micronized progesterone. Again, if somebody wants me to stop and say, oh my gosh, like, tease that out for me more, please let me know. But the point being that low dose vaginal estrogen has not been shown to raise blood levels of estrogen in the long run. And those products have a labeling, black box labeling, based off of truly a different set of treatments. And when we break down in additional studies, the subset of patients who only received vaginal estrogen products, it didn't show all of the scary stuff. There's actually, really interestingly, a petition that went out from NAMS, the North American Menopause Society, to the FDA a number of years back, asking the FDA to change the black box label on those vaginal estrogen products. And the FDA has not. But it is so important because patients will be prescribed this and they'll be scared. And if they're not empowered with the knowledge to contextualize this, then they can be very scared to use it and not end up using it. And there's even studies showing that because of this inappropriate messaging about vaginal estrogen risks, that there are women who have died died from getting really severe urinary infections that could have been prevented with vaginal estrogen, amongst other complications. So I just feel so passionately about correcting this kind of misinformation about these products. And certainly, me discussing this here is not to say that, everybody needs to feel comfortable having this discussion with their patients, especially when they're coming in for, physical therapy, but more so to just know that someone exists who can have this conversation with them, right? Again, if they feel comfortable going to their local provider, that's great. You can definitely send them to us at Odela to have this conversation. We're very happy to do so. But it's just one of the foundational discussions in this space. Okay, this is the other main takeaway about vaginal hormones that I just love and I'm completely obsessed with. Is this study. Okay, it was published in the New England Journal of Medicine, which is the most impactful or one of the most impactful medical journals in the entire world. And it was published back in 1993, so almost 30 years ago. And they basically did a randomized controlled trial of intravaginal estriol, that's a form of estrogen, in postmenopausal women with recurrent urinary tract infections, right? And what they showed was that when you use vaginal estrogen, the pH of the vagina goes down to its premenopausal healthy levels, and all this natural lactobacillus, which is supposed to live in your vagina and functions like your probiotic, comes back. Okay, and that it's extremely effective in reducing the rate of urinary tract infections when used consistently in this population. So the point being that, you can have patients, even if they're not sexually active or particularly concerned about vaginal dryness, who are saying, oh, I'm just, getting these debilitating UTIs. They're happening frequently. It's making me miserable. And vaginal estrogen is a key component of treating that as well, if they're postmenopausal or perimenopausal, right? Because there's a very strong physical way that we know this works, right? It's because it normalizes the vaginal pH, helps the lactobacillus to come back. Lactobacillus acts like the natural probiotic of the vagina, and it keeps bad bacteria like E. coli out of your urethra. So it's awesome. And there's like, people want to take things that are natural, right? They want to take probiotics, right? Using vaginal estrogen is better than a probiotic, right? It allows you to make your own. It allows you to reestablish your natural flora. So and this study just has not penetrated, the basic discussions that a lot of clinicians have with their patients as well. So, just a really important background point also to know that there's excellent data showing how and why vaginal estrogen reduces urinary tract infections. I saw some nonsense floating around the internet with a healthcare provider saying that testosterone could work for this, but estrogen hasn't been shown to do so, and that's just nonsense. It's just that we've known for so long that I think people aren't looking at the studies, even though they're excellent studies. Okay, so in terms of the female hormone management, again, this is counseling that we give people who come in for GSM to use 1 gram with a fingertip or applicator to the urethral area and vagina at least twice a week. In the beginning, they're going to be using it more frequently. So typically for the first few weeks, they're using it every day. And because of that, you may have some transient systemic absorption. Actually, for 2 reasons. 1, because you're using it every day in the beginning. And 2, because the vaginal wall, if it's very thin, can actually have more absorption into the bloodstream. But as that vaginal lining gets thicker and more robust, you will stop absorbing the vaginal estrogen. So it is true that some individuals, use vaginal estrogen in the beginning and they say, hey, I have a little bit of spotting and breast tenderness. It does not mean that these treatments are intended in the long run to raise blood estrogen levels, and they don't. It's just that it's normal for a transient period of time to have some of that absorption. And that's okay, and it's not associated with long-term complications. So just know that, for some reason, if your patient comes to you and, is scared to continue or feels like they were misled about it being a local treatment, this is pretty common. The other counseling I give is that, once you go through menopause, it doesn't reverse itself, right? So I tell people it's like brushing your teeth. You never go to your dentist and say, hey, I don't have any cavities. When can I stop brushing my teeth, right? Like you just have to do it forever. And same thing, with vaginal estrogen, if you're having a benefit from using vaginal estrogen, it's safe to use forever. And you will derive a benefit from using it forever. So your patients can take it from the time that they start going through menopause, basically, until they're dead. And that's perfectly fine. And it's great. And it will save them a lot of problems in the long run. And then my last comment on counseling is that irritation can be normal in the beginning when people are using these medications. So if somebody comes to you and says, hey, I'm having irritation from using this vaginal estrogen, I typically counsel them to, give it a few weeks because that is normal. A way of thinking about it is like, right, if somebody starts a retinol product, their skin gets irritated in the beginning, but they get used to it. So oftentimes they're acclimating. Certainly there are people who have true allergic reactions. Oftentimes that's a component of the base, not the actual hormone. So, that's when somebody can be referred to consider something like a compounded estrogen. I'm seeing some things here in the.
Yeah, we've got 2 questions in chat.
Yeah. So here so one of the questions is, I have patients who get recurrent yeast infections using vaginal estrogen creams or ovules, no previous history of yeast and not on antibiotics. What options do they have? They have GSM. So that's a great question. Definitely, there is a higher rate of yeast infections once you get estrogen back into the tissues. I wish I had a slam dunk way to prevent this. I don't. I think there are different options. They certainly can try. If they don't like the estrogen creams or suppositories, they can try other products that are on the market. There are ones like DHEA, that's Intrarosa. There are even oral medications for GSM. But, typically the way we look at it is, yeast infections, while really crappy, in the long run are much less dangerous than urinary tract infections. And, in the beginning, to give themselves some time to become acclimated, they also can just try lowering the dose, meaning instead of using it, let's say, a full gram twice a week, they can try using a half a gram twice a week, and tweaking it. But I do often, ask those people to try to give it some more time. And then the next question, it looks like, would there be any issues for those that are improving, but tissues are still compromised to use daily for longer than the initial 2 weeks before switching to twice a week? Since we aren't prescribers, would this be something we have them contact you about? Yeah, that is an awesome question. From the standpoint of not being prescribers, I guess just, from the standpoint of your own clinical, medical, legal responsibilities, you'd probably say, like, the best way to phrase that would probably be to, hey, talk to your prescriber about adjusting your dose. I think that would be very reasonable and within your scope to say that specifically. But, I don't necessarily think that they have to be using it daily for longer than 2 weeks, but it's possible that they would benefit from using it, let's say, 3 times a week. Yes, Odela can be this prescriber. We are very excited to be the prescriber of vaginal estrogen. And, so it is important to know that people are not going to feel the full benefit for sometimes up to 3 months. So they should do the once a day for 2 weeks and then go to the twice a week. And if they're really reaching that 3-month mark and they're not having resolution of their symptoms, or they're not showing full improvement on their physical exam, then that's when I say try it 3 times a week, for example. And that still is considered safe. And, the important thing to remember is that you have to treat to the symptoms and the physical exam findings, not to just this arbitrary number, right? Like I say with people, if you have high blood pressure, you wouldn't just take a pill and say, oh, my blood pressure is cured because I'm on this pill, right? Like, you want to recheck what the blood pressure is on the pill. The same thing with treating GSM. I mean, if somebody is on vaginal estrogen twice a week and they still have symptoms and signs of GSM, then, they need to increase their treatment, and that's okay. So yeah. Okay. These are all great questions. Let me make sure I'm going back. Oh. Okay. So moving forward, just to take a deeper dive on the effect of hormones on your genitourinary anatomy. So just to recap some of this anatomy, which I know many of you know. So you have your urethral meatus, which is where my cursor is here, right? And then you have actually this area called the vestibule, and then the hymenal ring is basically the inner border of this area called the vestibule, and then Hart's line is at what we call the medial border of the labia minora, and that's the lateral aspect of the vulvar vestibule. So this really critical area of tissue here between the hymenal ring and the labia minora, which contains the opening of the urethra, is this critical organ, right, called the vulvar vestibule. And that is embryologically derived from endoderm. And it's the same thing, or homolog, as the penile urethra. So, right, the urethra in somebody who's born with a male anatomy, is much longer than with female. And this tissue is actually part of the urethra. And it's really interesting, actually, if you ever have seen gender affirming surgery done, or what is phalloplasty, they will take this tissue of the vestibule and actually turn it into a tube to make the penile urethra. So it's even very much surgically used that way. But the important thing to know about that is, because it is truly has an anatomic basis in being part of the urethra, it can cause so many urinary symptoms. And it's very, very sensitive to both estrogens and androgens, right? So androgens being things like testosterone. And so we'll jump into that. But the important point being that if you have low levels of estrogen or testosterone or both, you can have very real urinary symptoms, and it can be a direct effect from the female urethra and bladder. It can also be from an effect on this vestibule tissue. Okay. So going here, again, this is just breaking down more what I was talking about in terms of the homologs, meaning again that area of vestibule, which here, in this circle here, does not have a color coding, is the equivalent of the penile urethra, and again, is really important for understanding sexual pain, pelvic pain, urinary symptoms in relationship to hormones, but also that there's a very significant sexual function, and actually the glands in that area lubricate in response to arousal when they're healthy. And that's very interestingly the same thing as pre-cum. So when somebody with female anatomy, gets aroused, there's lubrication that comes directly from the vagina, but there's also lubrication that comes from this vestibule, and those are two distinct types of lubrication. So you may even have a patient who says, hey, like I have sex and I lubricate like in response to penetration deeper, but near the opening it feels dry, or it's painful near the opening there, and it's possibly because of the direct effects of a hormone deficiency on that vestibule tissue. Okay. So just to recap, that vestibule, here's somebody looking at the vestibule on exam. And again, with my cursor, right? So here's where the hymen is, like I'm tracing it there, right? And that's obviously how you would enter the vagina. At the top of this screen is the urethral meatus. Sorry, where my cursor is right now is the urethral meatus. And looking at some of these arrows here, the Skene's glands are actually the homologs of the male prostatic ducts. The Bartholin's glands are the homolog of these Cowper's glands, and the minor vestibular glands are the homologs of this glands of Littré, which, again, you don't have to remember any of these things, just to really point out that there are true, corresponding organs. And that this tissue is really, functional and rich. And, I personally, in medical school, we weren't even taught this was an organ. We were taught like, hey, there's a urethra, and then you go to the back with a speculum and find the cervix and do a pap, right? Like, that's crazy. And how are we, especially, I mean, for the community of physicians in the world, going to adequately treat sexual pain disorders when we don't even have words for entire areas and organs. So really important stuff. Okay, so androgens. This is another topic that I just absolutely love in the sphere of hormones as they relate to pelvic health and pelvic symptoms. So yes, androgens are so critical to everyone's sexual health. There is a lot of misinformation regarding sex hormones, right? Primarily that women have lots of estradiol and men have lots of testosterone, and that it's kind of this binary phenomenon, and estrogen is for the ladies and testosterone is for the men, right? But that's like totally wrong. Everybody has estrogen, everybody has testosterone, and it's actually just different ratios, right? So this is a typical graph that people have in like physiology textbooks, and it's completely horrible. And if you look at it, it says, right, men have this high level of testosterone, this blue line, and women have these high levels of estrogen, it's this red line, and then converse for estrogen in males and testosterone in females. Well, that's like complete garbage, and it's not true, right? So moving forward, so if you actually drill down into this, right, when we talk about these sex steroid hormones, which are fairly equivalent in chemical makeup, they're very similar. So you can look at them on a kind of one-to-one basis. Estrogen is reported in picograms per ml, and testosterone is typically reported in nanograms per deciliter. And like, why is that important? Well, because it's a 1-to-10 ratio, meaning that estrogen actually exists even in females at a on average lower level than testosterone. And so if you were going to like take everyone's estrogen level and divide it by 10, then you would be looking at equivalence of estrogen and testosterone molecules, let's say, floating around in your bloodstream. So you could divide estrogen by 10 or multiply testosterone by 10, right? So this is a more accurate graph. And here what you're looking at is this top line with the black circles is the average testosterone level throughout the lifespan of a cisgender female. And the lower line with the clear circles is the average estrogen level or estradiol level in cisgender females throughout the lifespan. So it's actually that, there's more testosterone than estrogen, right? That's like crazy. Well, it's not crazy, it's normal, but we're taught to really underestimate the importance of testosterone, in females, and that just has to be massively re-educated. I think from our earliest learnings about puberty and sex physiology, this is just so key. All right. And I saw here, those with gender, sorry, I'm looking at our questions here real quickly. Those with gender affirming surgery, such as phalloplasty, does systemic testosterone positively impact urinary symptoms? Do these patients benefit from other supplemental medications? So that's an interesting question. What I most commonly see in transgender patients with a vestibule, so pre-gender affirming, bottom surgery, is that they're on testosterone, and they actually, that causes, like, the high levels of testosterone actually causes irritation of that vestibule tissue, and they can have really irritated, bothersome symptoms there, and actually benefit from estrogen cream in low dose. Obviously, after a phalloplasty, it would be very difficult to start shoving estrogen cream up your urethra, and I wouldn't recommend that. But that is an interesting area that I haven't really heard discussion about, would be how to treat ongoing urinary symptoms in people once they have a phalloplasty, if they're having them. So that's a really cool question. Oh gosh, there's so much more in this presentation, and we only have 10 more minutes. But I will keep going for the time being. Yes, we'll do a part 2. Okay, so just to put a little jargon here, we don't have to focus on all of this, but so a lot of our understanding of the very physical effects of androgens and estrogens comes from animal studies. Fortunately or unfortunately, that's where a lot of science starts. So in terms of the effect of androgens and estrogens, right, testosterones and estrogens in the bladder and urethra, this is kind of a summary of some of what we know, right? So there's both androgen receptor, that's AR, an estrogen receptor in the lining epithelium and the smooth muscle of both the urethra and bladder, right? And that's been shown in female rats. So that's really cool, right? Because again, when you hear this, discussion about GSM and somebody says, oh, vaginal estrogen can help with sensation of bladder urgency and frequency, right? That's not just like a voodoo statement. It's like there is a very real effect of yes, androgens, but also estrogens in your urethra and your bladder, and addressing that low hormone level can have a real effect and be synergistic with your pelvic therapy, right? So if somebody's coming in and they're perimenopausal or postmenopausal and they're having those symptoms, and you're talking to them about dietary interventions and pelvic floor relaxation, timing, this is like just part of the overall comprehensive treatment and going to make their treatments more effective. So again, that's that. Next bullet point below, receptor binding sites for estrogen and dihydrotestosterone, which we don't have to go into. This one below here, so overactomized female rats, basically, right, surgical menopause on female rats showed that there was changes in the bladder contractile response after their ovaries removed, and when they were given estradiol and testosterone, that was corrected. So that's interesting. This other bolded point here is just that giving testosterone in female rats that cannot turn their testosterone into estrogen because they're on letrozole, that they also had improvement of bladder relaxation, which is just quite interesting. And then also that testosterone levels have a direct correlation with the volume of urethral vaginal tissue, meaning that if somebody has stress leakage, there can definitely be a benefit to treating with hormones locally. Oftentimes patients with stress incontinence need other treatments, of course, pelvic therapy. Sometimes they need surgery, but definitely if they have symptoms of GSM, addressing local hormones is really important as one of the basic, non-invasive and safe interventions that can be done. Okay, so in terms of androgens and estrogens in the clitoris, labia, vestibule, right? So androgen receptor is in those vestibular Bartholin glands in humans. Estrogen receptor has been found in those minor vestibular glands in the cat. And interestingly, also, right, treatment with testosterone has been associated with increased engorgement of the clitoris. But again, there is actual improvement to the clitoris, vestibule, all these tissues with both androgens and estrogens. But I think it's so interesting how potent these are. And here's another comment on that, right? So in the final bullet point here, they were saying if you had, surgical menopause, and you were given estradiol, that you had improved engorgement of the clitoris with that estrogen. So really cool stuff. And again, not something that's requiring systemic treatments. Oftentimes you can treat a lot of these things, right? Bladder urgency, frequency, pain at the opening of the vagina, reduced engorgement, reduced orgasm, with these local treatments, because there's such a real effect. Okay. Again, what reduces androgens and estrogens in the pelvic tissues, right? Menopause, perimenopause, birth control. Again, I'm a huge fan of birth control. And but it's important to know, especially low dose oral contraceptive pills, particularly ones that have anti-androgens in them, have a really negative effect on sex steroids. It is for that reason that I will often say, it's fine for patients to go on oral contraceptive pills, but it's really important that their prescriber talks to them about sexual side effects and offers them treatments that have less sexual side effects. For example, intrauterine devices or progesterone only birth control. Let's see here. And spironolactone is another one that reduces androgens. So spironolactone, interestingly, is very popular recently for blood pressure because there's really good outcomes for people with heart failure. But it's an anti-androgen, right? And it's also used as an acne prescription, right? The reason it's used as an anti-acne prescription is because it lowers hormones, like it lowers testosterone. And so when you have these symptoms occurring from lowered androgens, that's called hormone-mediated vestibulodynia. And there's definitely a lot of overlap between that and GSM. Sorry, there's a question here. Does topical estrogen improve tissue health of the vestibule in women with lichen sclerosis who are using topical steroids? That is an awesome question also. Yeah, so the treatment for lichen sclerosis should include both a topical steroid like a corticosteroid, right? In conjunction with an estrogen for the internal tissues. So yes, it should be both. There are people with just such profound lichen sclerosis that maybe they can't get into the vagina even until they've been on treatment with topical steroids for some time. But those two things definitely go hand in hand. And if a patient is on a corticosteroid, like let's say clobetasol for lichen sclerosis, and they're having bladder symptoms or pelvic pain, and they're not on a vaginal estrogen, they really should talk to their prescriber, which can be Odela, about getting that on board for definitely. We're at the end of our time, so my presentation has more in it, but we will do that. We'll get back to that another time. And I'm going to stop sharing my screen, but if anybody wants to stay on and has questions for me, I'm happy to answer them.
You've got Dr. Winter, so if you have questions, feel free to unmute and ask.
I do.
Yeah, hi.
Hey, so this is more of a general question, but just in terms of the induction of a menopausal state with surgery, I understand removing the ovaries removes the ability to generate those hormones, but when it comes to hysterectomies and stuff like that, does that also have an impact on GSM symptoms?
Yeah, great question. So, it really comes down to whether or not the ovaries are removed. If their ovaries are intact and they have a hysterectomy, for the most part, they should not be having GSM symptoms. Definitely, we know there's lots of literature that just from the trauma of having a hysterectomy, you can have, pelvic pain and associated symptoms, and that's a very real thing. And I think the other confounder is just to remember that, as people who have had a hysterectomy, who have intact ovaries, because they're not menstruating anymore, as they move into perimenopause and menopause, they may not be aware of it because they don't have those periods to look for, right? Like oftentimes we diagnose menopause by saying, when was your last period? Well, like if you don't have uterus, you're not going to have a period, right? So, you know, I think the two takeaways, you know, are really that they should, while they have functioning ovaries, not have GSM symptoms, but that it's important to pay attention to their symptoms and uncouple, you know, their menopausal state from their periods, because we just don't know that anymore. So, yeah.
That makes a lot of sense. I guess I'm just trying to tie it for either younger patients or older patients who have a hysterectomy who may or may not have their ovaries intact, whether or not they would benefit from topical estrogens at that point.
Yeah, that's something, I mean, you know, on physical exam, if they have irritation, you know, it's something worth having them referred and discussing. You know, if there's some reason, some other reason, right? Like you can have intact ovaries and have other reasons for developing GSM, right? For example, premature ovarian failure, so meaning like early menopause, you know, which could be a thing. They could be on a medication that causes vestibulodynia, right, which has overlap with GSM, meaning like if they were taking spironolactone for acne and, you know, they could have very real need for a hormone treatment in that area, or if they have a history of using oral contraceptive pills before their hysterectomy, they could have developed this hormone-mediated vestibulodynia for that. So, you know, I think in those cases, if there is a question, you know, just saying, hey, I think you might have a reason to have a hormonal basis for some of your pain. Why don't you talk to somebody about that? I don't ever think there's something wrong there, you know? I mean, the worst thing is that they have an informed discussion about it, and they decide that it's not the right thing for them, but at least they've been offered that. And unfortunately, too many people, you know, are not offered that discussion, or had no idea that, you know, even let's say at 30, that there could be a hormonal component to their pelvic pain. So maybe that answers it a little better.
Thank you.
All right, awesome. Anyone else?
Thanks, Ashley, for the presentation.
Hi.
Hi.
Yeah.
So question, because this has come up a little bit, with this black box warning that's on the vaginal estradiol, it's become a little bit of a predicament where I'm calling it the physical therapist versus the FDA, which is kind of not a good place to be in.
All of us versus the FDA.
Right? But
All of
how
us.
did we, if technically we're not supposed to discuss this, even though I know there's a whole range of comfort with the skills that physical therapists have, is there a resource that we can point people to that explains this black box situation in a way that patients can understand?
Yes. So I spent a significant amount of time yesterday for our Odela website, putting a contextualizing preface to this black box warning information. We don't have it up on our website yet, but once we have it up, it will have links, for example, to the letter that that NAM sent to the FDA, and the reasoning. Yeah, we can post all of that info in the Facebook group as well, and share with you guys. And then I plan on making a kind of a more fleshed out, you know, type blog post about this. But yes, 100%. You know, I don't think anybody has to go outside their comfort zone and start saying like physical therapist versus FDA. You can always point to resources from exactly like North American Menopause Society, where very vocal doctors there, who are experts in this, have been like yelling at the FDA. And so it doesn't have to be your voice alone. It can, like, you know, we'll provide the resources to you so you can share those statements with your patients, and they can be like, oh wow, like, you know. And when I say, it's kind of like, you know, the FDA doesn't really seem to care about vulvas. I'm sorry, but they don't, and that's unfortunately true. and you know, I think a lot of patients, when they think about that, they're like, yeah, you know, it takes time and sophistication to put the effort in to care about vulvar health, and look at this data with nuance, and the FDA is too lazy to do it. Yes, Amy is raising.
Hi, can you hear me okay?
Yeah.
Okay. I work with Dr. Rachel Rubin, a bunch. I'm
Oh,
on
yeah.
a couple of different committees with her, but I have told her a few times, she's obviously busy, but I have been taking vulvar applied estrogen testosterone compounded creams since, I don't know, I was like 30 years old, so maybe about 11, 12 years now.
Mm.
So if anybody needs like a case report of somebody who's been taking this for an extended amount of time, a younger person, not in menopause, I have my blood tests that show that none of my levels systemically raise. I don't have any like breast tissue problems. I don't have any uterine problems like, cancers or growths or ovary growths or anything like that. So it's been an interesting ride, but I'm like, I don't know how they can't see that this doesn't cause these longer term issues when I'm like, I've been on it for so long with no issues. So I'm
Yeah,
available
that's
if anybody needs
amazing.
to make a case report for the FDA to get them to deal with this.
No, I love that. Thank you so much for sharing and your transparency about that. It takes a lot of bravery to, talk about your vulva and to a Zoom room. But I like it, it's amazing that you're able to share that with us. And definitely we can stay in touch. And I think there's such a role not only even just for case reports, but patient advocacy. I think a lot of our patients need to hear from others who have been down that path before. And I agree with you. I mean, over the years, I've prescribed vaginal hormones to many people who are well before menopause. And they, I think there's a lot of a barrier to believing that these treatments have a role in patients of all ages, but they really do. So yeah. Anybody else raising their hands? I don't think so. Great. Well, again, that presentation was somewhat incomplete because it was so long, but I'm so excited by all the questions you have asked, and we can definitely do another one and continue this and round it out. And if anybody has any other thoughts on topics they'd like to discuss, I would love to take deep dives, or if you want to spend time on specific questions, you can write me ahead of time and we can make that like a Zoom discussion as well. So yeah. And I think as a capstone to this, of course, just to say that at Odela, we are here to take any patient consults that you feel are people that might benefit from having these sort of discussions, and we're very excited to all work together for sexual health.
Thank you, Dr. Winter.
Thank you.
All right, thank you. Thanks, everyone.